Again, thank you very much for allowing me to talk today. I'm going to be going over robotic hepatic surgery and why are we doing it? Who do we do it for? And how do we make sure we do it well? So the data on minimally invasive liver surgery is clear, but it's primarily based on single or multi-institutional retrospective series until two relatively recent publications came out of randomized controlled trials, the Oslo Comet and the lab Opuva, that randomized patients with colorectal liver metastases to lap versus open parenchymal sparing hepatectomy. Notice that there's no randomized controlled trial with regards to robotic surgery, and we'll go into that later. So, but on the basis of these trials, it's important to notice that the minimally invasive approach is associated with fewer complications, a shorter length of stay in the hospital, a lower need for pain medications, which is so relevant and important, as you heard from Dr. Zhang, but importantly, no compromise in resection margin. There was a follow-up study to this that showed long-term oncologic outcomes, and there was no difference with regards to overall or recurrence-free survival. And these results were replicated in the lab Opuva study, where there was no difference long-term in oncologic outcomes, nor in return to intended adjuvant therapy. And the following videos show you why it is that we think the minimally invasive approach has these short-term benefits. There is a tamponading effect to pneumoperitoneum of the pneumoperitoneum. So here you can see there's a hole in the vein. And if you were to do this in the open setting, you'd have blood come pouring out of that hole throughout the case. But here, because you have the pneumoperitoneum, what you do is you lift up and you create a vertical column of blood, and the air won't go in because the blood is staying in the dependent portion. And then with regards to length of stay, you can see an example here. This is a lady who had colorectal liver mets, one in the caudate lobe, one in segment 6. I took her to the operating room. I did a robotic partial hepatectomy × 2, including of the caudate lobe. She was discharged on post-op day 1 with negative margins. She recurred, her disease recurred later, deep in segment 5, and you can see where it is. In this case, I took her to the operating room and did a lap partial hepatectomy with a very deep dissection. You can see here a hepatic vein that I had to divide. It's a crater going about 5.5 centimeters deep, and she was discharged home post-op day 1. Again, negative margins and some tumor viability. So this kind of approach is only possible because the patient is contending with much smaller incisions with a minimally invasive approach compared to an open approach. So we here at Anderson, we like to use a modified Mikuchi incision when we do open surgery. And really, this is what the patient's staying in the hospital for, is recovery from this incision. When we do a robotic surgery, these are the ports I put in. The biggest incision, if I do create one, is the fan and steel incision, which is my preferred extraction incision site for larger specimens. When we look at the learning curve for robotic surgery, it depends on what you're looking at. In this paper here, in JOGS in 2019, they looked at the rate of conversion. And the conversion basically was lowest. Basically, it peaked after 30 cases, and following 30 cases, your conversion rate was lower. Now, the experience of this group, though, was that this was minor hepatectomy included, and primarily minor hepatectomy. And they had very little experience with the robotic platform itself. Others have looked at this for major hepatectomy as well. And in this study by Zhu et al., what they found is that their experience could be broken down into 3 curves before it became more or less standard of care for them. In the initial phase, they had a lot of, the operative time was very long, and the length of stay after surgery was very long. They reached that at about 15 cases, after which that curve in terms of operative time and length of stay started flattening out. It took another 25 cases for them to drastically reduce the amount of blood loss they were experiencing, and catastrophic blood loss, it was described. And then after that was a mature phase, where it took about another 52 cases for them to reach a steady level, after which they felt like their future robotic experience was well described and achieved a steady set of outcomes. At MD Anderson, we make sure to train our fellows and our faculty in the best possible way so that to set them up for success. And this is set up through a number of different ways. One was, setting up simulation access around the clock. So we have a dedicated robotic training console. And you can see here, your very own Federico Opliger, who was with us and whom we were very happy to have with us this last year. He actually came in, he had no experience with the robot, but I will tell you, he was very impressive. His robotic skills, just natural robotic skills, were excellent. So understanding what the robotic platform can do helps a lot. It helps a lot to achieve good outcomes. So what should you tackle and when should you tackle it? I say to start small, start slow, and grow your experience, right? So build and common skills. So in the setting of liver surgery, you're all familiar with the Iwate criteria or other criteria to classify the complexity of laparoscopic liver surgery. One that we use at MD Anderson to just simplify things is the Kawaguchi-Gaie classification system. But as you're starting out, you should look to start tackling the simpler cases, like a partial hepatectomy of the anterior segments or a left lateral sectionectomy, which, for instance, Federico, by the time he was done, was able to do on his own at the console. Then you progressed on to formal segmentectomies or left hepatectomies. And then once you've done that, you can progress to tackle bigger cases like a right posterior sectomy or right hepatectomy or an extended hepatectomy. There are benefits for sure to building a robotic surgery program concentrating in HPB. From a marketing standpoint, it can draw in new patients. It's an easy to produce kind of outreach tool. A lot of patients come in asking us if we offer robotic surgery. There's no question that there are benefits in the short term that have been realized. So this table here shows our outcomes at MD Anderson. You will see that our median length of stay after robotic, especially robotic hepatectomy, was 2 days. 2 days. When you compare that to our open, even most simple, straightforward hepatectomy, it's equivalent, if not a little shorter. And so which approach, I'm sorry, let me go back. The other thing is that patients have decreased pain, minimized their opioid use, have a quicker recovery. And then it's just something that we for our sake is a good research and education platform for our fellows when they come here. So which approach do I use, knowing all of the things that I know for which patient? The open surgery is still favored for me when I tackle patients with severe cardiopulmonary disease, those where I'm going to do a complex combo case, or patients who have multiple tumors in different parts of the liver, where trying to adjust the bed will be very challenging, and trying to get to the different parts of the liver may require repositioning. And at the end of the day, you're ending up taking too much time and you're leaving the patient under the anesthesia for too long. I still use the laparoscopic approach, but by far and away, we are now favoring the robotic surgery approach. And the laparoscopic approach I prefer for tumors that sit on blood vessels, where I need to use the laparoscopic CUSA, the ultrasonic dissection and aspiration instrument, so that I can really kind of carve the tumor off of the vessel. And you will see in the videos I show later that in robotic surgery, we just don't have that fine tool, but we've made do without. And then robotic surgery, honestly, I use it for all other cases, but especially for those who are obese, where opening them and doing a big open incision is going to be, a lot of work, and trying to dig deep into their body can be a lot of work. For patients who have multiple tumors, That's better than the laparoscopic approach. And then any case where you think suturing might be required. So with that, as Dr. Zhang said, we keep a very close eye on our outcome. And I think that's really important to do. You have to keep tabs on your experience so you know what you're doing right. You identify what you're doing wrong and you can fix it, right? So this is just the experience between March 2019 when I kind of started at MD Anderson and then June 2021, which is the last time. And this is mostly my experience. There's a few other cases. There's a number of other cases from my partners that I haven't put in here. I excluded 24 combo cases. You'll see my laparoscopic cases, I have really largely shifted to now robotic cases. And we're doing a lot of livers and then extrahepatic biliary and duodenal tumors. Our mortality rate is 0. Median length of stay is 2 days. With a number of them being outpatient surgeries. And again, comparing that to our open Kawaguchi type 1, more straightforward open surgery, the median length of stay about 3 days. And our bile leak rate was 1 out of 69 cases for the liver, which is 1.4%. So that ends this portion of my talk.